Okay. All right, so hypertension is something that you are going to see a lot of in your practice. It is a chronic condition that affects a lot of people. Approximately 70 million people, or 1 in 3 adults in the United States at the current time, have high blood pressure. That's a lot of people. Only 52% of those 70 million people have their blood pressure under control. Hypertension does place people at risk for heart disease, eventually heart failure. It is the leading cause of stroke. It can cause kidney disease and then the potential to lose your sight. So it is pretty serious. These patients need a lot of education. So what are some risk factors? So hypertension is just an elevation in your systolic and or your diastolic pressures. Research has never actually been able to determine the actual cause. We have a couple different things that we know for a fact that contributes to it. So as we get older, we know we have a lot of changes in our vessels and our arteries. They lose their elasticity. So we do tend to see a small rise in our blood pressure as we get older. Sometimes our genetic predisposition has a play. You know, if our loved ones before us, our mothers and fathers, our grandparents had some type of cardiac issue and hypertension, we see that that can be passed on. It does affect African Americans at a much higher rate than it does all other ethnic groups. Obviously, if you're obese, if you're inactive, smoking, excessive alcohol intake, and then ineffective stress management is also at risk. So all you guys are at risk for developing hypertension because I know you guys are all stressed out because of nursing school. All right, so once was once considered a normal blood pressure measurement, just not recently, just as most recent as like 8 years ago when I was in nursing school. A systolic pressure of 120 and a diastolic pressure of 80 are now the lower ranges of pre-hypertension. So when I was in nursing school, this was considered hypertension, but now because a lot of people don't address it soon enough, and we're seeing so many other things develop because of uncontrolled high blood pressure, they have changed the parameters. So 120 over 80 is now pre-hypertension. Pre-hypertension is defined, and you need to know your values, your parameters. Pre-hypertension is defined as a systolic blood pressure of 120 to 139, or a diastolic blood pressure between 80 and 89. Hypertension is sustained elevations in systolic or diastolic blood pressure that exceed those pre-hypertension levels. And we now divide our hypertension into 2 categories. So we have stage 1 hypertension and stage 2. Stage 1 hypertension is defined as a systolic blood pressure of 140 to 159, or diastolic between 90 and 99. And then stage 2 is blood pressure that equals or exceeds 160, or a diastolic pressure that's equal to or exceeds 100. We can also define hypertension. We can divide hypertension into 2 main categories. So we can have essential hypertension, which is primary. Also, you might hear it referred to as idiopathic, or secondary. So essential hypertension is what we see most commonly. It's going to be in about 95% of our cases, and it's just a sustained elevated blood pressure with no known cause, no comorbidities. The patient exercises, they're healthy, they eat great, they're doing all the things that they should do, but they still have hypertension. And then secondary hypertension is when you have elevated blood pressure that results from or is secondary to another disorder. So maybe your patient has coronary artery disease and then they developed hypertension, and then we have also, which is not a category, but some patients will get what's called white coat syndrome. So their blood pressure is completely normal 365 days a year, but they have to go to the doctor for their yearly checkup. And as soon as someone takes their blood pressure skyrockets through the roof. We call that white coat. So what does hypertension do to our heart? It increases the workload of our heart. Our heart has to pump against resistance. When our heart continuously pumps against resistance, the size of our heart muscle increases. Our heart is a muscle, so the more you work it out, the more it's going to get larger. As it gets larger, it will not pump as effectively. It's not going to be able to contract as well as it normally did. It gets stiffer. So the heart can no longer pump adequately in order to meet what our body requires. When that happens, we're going to start to see heart failure. The extra work and the greater mass increase in the heart is going to require more oxygenation. The myocardium is not going to be able to receive sufficient oxygenated blood. If we can't get blood to the heart, we're going to see that ischemia. And then the client is going to experience angina. Remember, we said angina is that chest pain. So high blood pressure is going to damage those our arterial vascular system, and it is going to accelerate the rate of atherosclerosis. It's going to cause increased resistance in the arterioles to the flow of blood, which is going to cause complications in all the other organs. So it's going to affect our eyes, it's going to affect our brain, our heart, our kidneys. All of our organs are not going to be able to be properly perfused. So you're going to see damage. Arteries in the retina, you can see hemorrhage there. This is going to, over time, cause a marked visual disturbance, and eventually it can cause blindness. Your patient could have a stroke or a hemorrhage. So you could have a hemorrhagic or a stroke with an occlusion. Because of high blood pressure, you can have a myocardial infarction, an MI, which is also a heart attack, and then impaired circulation to the kidneys. So you'll see a lot of these patients over time that have had uncontrolled high blood pressure will end up on dialysis because their kidneys stop functioning because they don't get good blood flow to them. So this is just a good chart for you guys. You guys can study this. This just classifies the different stages of hypertension and what the appropriate parameters would be. You guys do need to know that for testing. So this is a good picture. I got this from your book. So on the left is a normal heart, normal size, the way it should look. Over here on the right is a hypertensive heart. So you can tell from years of having to pump harder and harder and harder, that muscle has gotten a lot bigger and it's really thick, and then it's going to lose its elasticity and it's not going to get the proper blood flow out. So what are the clinical manifestations that we're going to see because of high blood pressure? It's going to increase the afterload of the heart. We're going to see myocardial hypertrophy, so that muscle is going to increase. Your patients are going to complain of chest pain. They might have an MI, eventually heart failure, pulmonary edema, aneurysms. We're going to see that renal vascular damage because of that decreased renal perfusion. So your patients that come in and you're looking at labs, you're going to see protein spilling into their urine. You're going to see hematuria. Those labs, your BUN and your creatinine, they're going to be elevated. That's going to be your indicators of kidney function. And then these patients are going to be in chronic renal failure, and then eventually end-stage renal disease. So they might not even be making urine by the time they get to this end-stage renal disease point when they're on dialysis. Some of them just make a tiny bit of urine. Some of them don't make urine at all. And then you're going to have that damage or that decreased blood flow in this cerebrovascular system. So your patients can have TIAs, which are usually, they don't last long, less than an hour. They're kind of like mini strokes. They usually come before a big stroke. Usually if your patient is presenting with multiple TIAs, that's a good indicator that a stroke is probably not too far out, or they could just actually have a CVA. They can have epistaxis and then retinopathy. So lots of vision problems. So I pulled this from your book. You guys can take a look at this. This is the effects that hypertension has on all of our target organs. And this is just some of the causes. So we know if we have excess salt in our diet, we're going to have increased hypertension. Why do you think that salt is going to increase our blood volume? Why do you think that happens?
Because water follows salt.
Very good. Yep. So you're going to have that increased circulating volume all the time. So you're going to want to avoid those processed foods. You're going to eat a healthy diet. Don't use salt. We can have abnormal arteries, increased blood volume. We talked about those genetic components that can cause it, having a stressful life. Those are all your essential hypertension causes. Your secondary hypertension causes, we can see it with certain health conditions. Sometimes medications will cause it. Recreational drug use, we see it in pregnancy, and then in hormonal therapy too, especially we see it in birth control pills. That's a big side effect of certain oral contraceptives. All right, so what are some of the diagnostic findings we're going to see for patients that have hypertension? So what our aim is to perform tests that are going to be able to determine the extent of organ damage. So we know that they have high blood pressure, but we want to figure there's really no way, unless the patient's been monitored on a regular basis by the doctor before that, to determine how long they've had it. So we need to determine what extent the kidneys have been damaged, the liver, their eyesight. So we could do a chest x-ray, which could take a look at the heart, and it would show that that left ventricle is enlarged. And it's going to be the left ventricle because that is the side of the heart that's pumping that blood out with each contraction to contribute to our circulatory volume. We can do an echocardiogram. This also is going to take a lot of measurements and pictures, and it's going to reveal that that left ventricle is enlarged. And then we can always do a 12-lead EKG, which would reveal some abnormal heart rhythms. So we can do a CBC, take a look at those values. We can look at some fasting blood sugars, because usually if patients have hypertension, not all the time, but we do see a lot of these other comorbidities. So these patients will have diabetes. They're going to have high cholesterol. High cholesterol and hypertension often go hand in hand. So we're going to do that lipid panel. We're going to look at their triglycerides, all their cholesterol levels. We're going to look at their BUN and creatinine, especially because we really need to determine that kidney function. And then we want to look at their electrolytes. We also, as nurses, want to do a psychosocial assessment. So we want to know what's going on in their life. Are they in nursing school and they're completely stressed out? Did they just have a baby and they're not getting any sleep and they're working a lot of hours? What's going on in their life? Do they have any stress? Are they sedentary? Do they work out 3 to 5 days a week for at least 30 minutes a day? What's their diet like? We need to know all those psychosocial aspects. And then medication assessment. So we want to find out what medications they're taking now. Sometimes patients suffer with low blood pressure. So we give them medicine every day to help bring it up. We can always cause the opposite. We know that whenever we're trying to fix one thing, we can cause another. And there are just certain medications that can increase your blood pressure. So we want to do a good med reconciliation when those patients come into the hospital. So we want to confirm the diagnosis, do all the things that we talked about on the previous slide there. When patients go into the primary care setting or when they're in the hospital, we have to have the gold standard is that in order to diagnose hypertension, we want to see elevated readings in both arms on 3 separate days. So yes, our blood pressure could be elevated today, but tomorrow if we check it, or if we check it in another arm, it can be completely lower. So that's the rule of thumb. The patient would come back to the primary care facility over a period of a couple of days, and they would monitor that blood pressure before they made a diagnosis. And then usually what they do in the primary care setting, if it's not at a dangerous level, if it's not like 198 over 100, they probably wouldn't do anything. They would just educate the patient You would obviously look at all their comorbidities, but you would just educate the patient that I need you to start working out. This is the diet that I want you to follow. Make sure you're getting proper rest. Let's talk about some stress management activities. Of course, if it was extremely elevated, then we would have to do some type of pharmacological intervention because we know that the heart cannot sustain blood pressure levels for too long of a period without causing major damage. So we would do ambulatory blood pressure monitoring. If you're in the hospital, again, and this is, they say they don't have a history, we're just going to watch it. You know, we always do things, we always handle things differently in the hospital than we do in the acute care setting. In the hospital, things seem to be much more of a concern than they appear to be in the outpatient setting. So we might give medication. We might just watch it depending on what other issues they're experiencing. The primary objective, obviously, is to lower that blood pressure and prevent any major complications. So non-pharmacologic interventions for the patient, that is going to be those lifestyle changes. So we want them, we want to look at their BMI, show them where they should be on the chart, encourage them to start losing weight. A lot of people don't know how to have a proper diet or what to eat. So you can always make referrals to nutritionists, or if you're still in the hospital, have the doctor put in a referral, have that nutritionist come see them before they're discharged. We want them to safely engage in exercise. So sometimes when their blood pressure is too high, we don't want them to go out and exercise because that's going to be more work for the heart. So we always follow the doctor's guidelines. And when it's appropriate to do so, then we would educate them to exercise. We want them to decrease that sodium intake and then reduce the amount of alcohol and smoking that they do. And it is very, very possible that if your patient is compliant, that you can see a major improvement without pharmacological interventions. Sometimes, because of genetic reasons, these patients will do everything they're supposed to do, and we still don't see an improvement. And we will wind up doing those pharmacological interventions. Oops. All right, so patient teaching for lifestyle modification. So again, control the risk factors to help minimize disease progression. So assist the patient to be able to identify those modifiable risk factors. We can tell them, but we need them to know that these are the important things. These are the things we want them to work on. Weight, food choices, alcohol, smoking, exercise. And then we need to make sure we're providing the patient with the resources they need once they get into the community. So, you know, where are the local gyms? Sometimes there are nutrition centers and little kind of like mom and pop exercise places that work with the hospital and offer discounts for gym memberships and stuff. So we could always talk to our care managers or case managers at the hospital. And then we want to educate the patient on the possible complications of progressive hypertension. People that don't work in the healthcare field don't know that they can go blind, that they can get their feet cut off. I mean, because this is what's going to happen eventually. When you don't get that good blood flow, you're going to need a kidney transplant. You're going to be on dialysis for the rest of your life. You know, your feet are the furthest part away from your body. So if you're not getting good blood flow from your heart all the way down to your feet, you're eventually they're going to become gangrenous. Because of lack of blood flow, you're going to start losing toes and feet. It's just that serious. So these patients need to know these things. Sometimes that's still not enough for people. Sometimes it is. So we need to let them know. And then we need to emphasize that successful management of hypertension can reduce that damage that we see to the other organs. So these patients require a lot of education. You guys haven't seen a pattern yet in all your schools so far. The nurses, one of the biggest things you do is teach, teach, teach. So when we talk specifically about weight reduction, we want, if we see a patient with a BMI of 27 or greater, this is where we want to intervene and encourage weight loss. So these are patients that have a waist measurement greater than 40 inches. In males, and then greater than 35 inches in feet. Or is that the opposite way? Which one's the female? I don't even know those symbols anymore.
Trish, sorry. It's some students trying to get underneath it.
Oh, thank you. Okay, they should be in now. Carrying this excess weight does put patients at risk for what we call metabolic syndrome. We're going to talk a little bit more about that. So we want to tell them to limit their fat. It should be less than 30% of their daily calories. We want to limit their saturated fat, less than 10% of their calories. And then we want to limit their cholesterol, less than 300 milligrams a day. So if we just say we want your fat to be less than 30% and your saturated fat less than 10, that's probably not sufficient for just the average person that doesn't have any kind of health experience or nutrition experience. So these patients need help breaking that down. What would a typical day look like? Let's work a diet. Let's learn how to read the back of our labels on our containers, because that's how you're going to determine what your percentages are. So we need to do a lot of teaching with their meals. Planning meals is a good way to do it. That's why I said refer them to the nutritionist. Have that nutritionist stop by the room before they're discharged, so at least they have some kind of idea. Work with them when they're inpatient to, usually if they have a high blood pressure or any kind of heart issue, the doctor's going to put them on a heart-healthy diet. So when they call down to order their food, they're going to be told, well, you can't order that. It's not heart-healthy, blah, 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 blah. So you can work with your patient for their meals. Come to the room with them and say, okay, let's talk about what you want to order today. And then if they want to order bacon, then you might want to say that's not a good idea. That's too high in fat. Let's make a better choice. So really help them look at their meals. So we can also tell them about the DASH diet. So the DASH is Dietary Approaches to Stop Hypertension. You'll find this all over the American Heart Association. They designed this program. It is basically a diet that is rich in whole grain, fruit, vegetables, and low-fat dairy products with a reduced content of saturated and total fats. So the Heart Association recommends that you follow this diet to decrease your hypertension, and it is effective. So consult that dietitian and then refer to a weight loss group or organization. So we talked about sodium restriction. So we are going to recommend that they reduce their daily sodium intake to 2.3 grams of sodium, which is 6 grams of sodium chloride per day. We want to avoid salt at the table. We want to avoid cooking with salt. And then we want to avoid seasonings, because while they make your food taste better, they can contain a lot of sodium. But there are a lot of things out there that you can buy, different seasonings that don't contain sodium, that are very good. Limit your consumption of canned, frozen, or processed food. They are loaded with high amounts of salt. Suggest spices, herbs, fruits, and other non-salting containing flavor enhancers. Salt substitute. Remember back to homeostasis, a lot of patients that have hypertension wind up having issues with their potassium because salt substitutes has large amounts of potassium in it. So you can recommend them. Certainly it's going to be better than salt, but they also want to watch their intake of that as well. We want them to read their labels, be conscious of the sodium, the fat, and then again, consult that dietitian. Moderation of alcohol intake. So men should limit less than or equal to 2 drinks per day, which 2 drinks a day is still pretty reasonable, I think. Women and lighter weight individuals should limit their drinking to less than or equal to 1 drink per day. So 1 drink is the equivalent of a 12-ounce beer, 5 ounces of wine, or 1.5 ounces of 80 proof whiskey. So you need to know these, you need to know what we're talking about when we talk about alcohol. So 1 drink is 12 ounces. You're going to see that on your test. Exercise. The heart is a muscle. It does need exercise. So exercising 30 minutes a day, we say 3 to 5 days a week, can help you lose weight, which will, over time, lower your blood pressure. We can teach relaxation techniques, especially for the patients that are stressed out. So yoga, music therapy, they can participate in anything that is relaxing to them. I don't personally find exercise relaxing, so that probably wouldn't be something that I choose. And then we don't want to encourage them to stop smoking. So this is a great slide. This shows all of the cancer-causing carcinogens that are in cigarettes, all the poisons. So not only does it cause cancer, we know it contributes to heart disease. So this is good. This is something you could share with your patients that are thinking about stopping smoking. And then decrease stress. So we have two types of methods that we can use to decrease stress. We have direct methods and indirect methods. So direct methods would be time management. So we're always stressed out. We're always running last minute. So many things to do. You know, taking time at the beginning of your week to look at your calendar, plan your time better so that you're not so stressed out. Figure out what's causing you stress and make a plan to manage it. If you have too much on your plate, delegate. I know you guys can really associate with these with what we're talking about now, because you guys are working and you're taking care of your families and you're trying to be a full-time nursing student. It's a lot. So learning how to delegate. We have a lot of people have problems with that. They're just doers and they like to handle everything, but sometimes we have to ask for help, and that's okay. Assertive communication to discuss issues. So if there's problems at home or problems at work, you can still be respectful and mindful, but assertive. So that way, any issues that you're dealing with, you can try and resolve. And then sometimes you just have to remove yourself from the situation, no matter what it is, for your own health and your own mental well-being. And then those indirect methods, this is going to be methods that induce relaxation responses. So if you like yoga, or you like sitting by the beach, or you like having, a hot cup of tea at night, anything that's going to allow you to enjoy some type of relaxation. Recognize and accept your limitations. Know that these are the things that are stressing you out. I mean, when I was in nursing school, I just had to lower my standards a little bit, and I had to realize that I couldn't be all to everybody, and maybe my dishes were going to pile up a couple times during the week. Maybe I had to, keep asking my husband to take the trash out, whatever. We need to know what we're capable of and be okay with it. Develop and refine a sense of humor. Develop and maintain a support system. So make sure you have people in your tribe that you can go to when you need support. They can take your kids for the night, or just give you a little pep talk, or bring you a meal when you can't cook because you're studying. Try to be tolerant and forgiving. Show yourself grace. That's one of the things I've learned in the past year, is that we are extremely hard on ourselves. We have such high expectations of ourselves, but every now and then we need to show ourselves some grace. We are only human. And be good to yourself. Treat yourself to things that you deserve. You guys work hard. All right, so sometimes when we've done all the things we just talked about and things still don't change, maybe the patient's non-compliant, or maybe they have some genetic predispositions that are not allowing their blood pressure to budge, we have to use pharmacological interventions. So we can, there's evidence-based practice guidelines. So we have, we look at patient variables. So usually the first thing that a primary care provider will provide is they'll just add on a fluid pill. Hydrochlorothiazide is the gold label that we go to as advanced practitioners. But with that being said, you have to look at other things. So what other coexisting diseases do they have? What other current medications are they on? What kind of drug allergies do they have? So what the gold standard is might not be what we are able to use to based upon other conditions that the patient may have. So that's the first thing we're going to look at. And then we're going to look at the pharmacokinetics of that individual agent. So what is their mechanism of action? How long is it going to take to last to work, and how long is it going to last? What are the side effects, and what are the potential adverse effects? And then we want to look at protocols for administering those pharmacological agents. What kind of monitoring has to be done? So in the hospital, we're kind of thinking of, do they have to be on a monitor unit? We can't give certain medications unless they're on a telemetry monitor. So they would have to be on a telemetry floor. And then if the patient is already receiving a pharmacological agent to manage hypertension and still remains hypertensive, then the provider may increase the dose of the agent. So you guys know when we prescribe medicine that we always start, like our mental health medications, we start out at the lowest dose that's going to be effective, and then we work our way up. So a lot of these medicines still have, a higher ceiling. We can, increase those doses. We can just add you would see these in the hospital setting. You could order a stat additional dose. So it's not something that the patient's going to have continuously, but we're just going to give them this one-time dose to try and really bring down that blood pressure. We could change to a different hypertensive agent altogether, or we can add an additional class of hypertensives. So this is really important. So as a nurse, you should be doing this in clinical. I don't know what your clinical instructors are like. I know when I taught my students and how I do it in my practice is I always tell my patient exactly what I'm giving them and why they're getting it. So Mr. Jones, I have your metoprolol today. I have your amlodipine for your heart and your blood pressure. I always explain to them what they're getting and why they are getting it, how it works in the body. Maybe not so much how it works, but what it's for. This is your metoprolol. This is going to help control your heart rate because sometimes your heart rate is abnormal. This is your amlodipine. This is going to control your blood pressure. Sometimes when you're talking to your patients and you're telling them what medicines they have, you might be giving them 3 blood pressure medications. I can't tell you multiple times I've had patients say, why am I getting 3 or 4 different blood pressure medicines? Is that normal? Yes, because they all have different mechanism of actions. They're all from different classifications. So you need to know how these medications work. So, well, this is a beta blocker. This works by doing this. This is a calcium channel blocker. This works in a different way. So your patients need to understand why they're taking that medication and how it works in their body. Most of them just take a pill and they don't even know every day. Their primary care providers don't educate them. So when your patients ask you questions like that, you need to know how these medications work so that you can educate them. Self-monitoring at home. So if you have a patient that's in the hospital that has been diagnosed with high blood pressure, we want to make sure that they're educated and they know that they can't just forget about this once they go home. So we want to make sure they're following up with their primary healthcare provider until they get to a stage of maintenance. Depending on the level of their blood pressure, they're going to be seeing their healthcare provider every 30 days. Minimum. Sooner if their blood pressure is very uncontrolled and they're doing medication management. Once they go back to the doctors like every 30 days for like 3 months and we're seeing a control in that blood pressure, then the provider will start just calling in those prescription refills, and then they come like every 3 weeks. They come quarterly. They're going to want to monitor for those therapeutic and non-therapeutic effects of medication. So we want them to know what high blood pressure feels like. For a lot of people, they don't notice anything. Some people will notice a headache. They can tell when their blood pressure's up because they'll get a headache. We want them to recognize the symptoms of low blood pressure because if we're giving them medicines to take, we always know that they're at risk for developing low blood pressure. So we want to educate them about what that's going to feel like. So dizziness, it could be chest pain. We want to educate them to sit at the side of the bed before they get up in the morning, dangle their feet, make sure that they don't feel dizzy. And then if they experience these symptoms, they need to call their healthcare provider. They should be monitoring their blood pressure at home. If they don't have a blood pressure cuff, they should get one. If they have issues with insurance or money, you can always talk to the case manager. Sometimes certain insurance companies will pay for the patient to have a blood pressure cuff, and the case managers can give them a coupon, or they can actually get a hold of one and send it home with them. If it's a new patient that's just diagnosed, we really want them to monitor their blood pressure every morning at the same time. And then keep a log, and they should bring that log back to their primary care physician with them so that the doctor can see, because if they just come in once a month and they're only doing blood pressure once in the office, that's really not a good indicator of how their blood pressure, how stable it has been or how unstable it has been. So educating the patients about signs and symptoms of hypotension, we said that. Yep, tell them to sit at the edge of the bed, rise slowly. Current recommendations from the American Heart Association are that automated devices that you should use, automated devices that measure blood pressure on the upper arm. That is where it is most accurate. Monitoring your blood pressure at home is never a substitute for follow-up with your regular primary care physician. These are things we do in addition to seeing that primary care doctor. And then we also want to tell our patients that they should bring that their blood pressure monitor into the doctor's office at least on a yearly basis so they can compare it to theirs to make sure that it is working appropriately and taking good measurements of their blood pressure. So some patients will experience what's called a hypertensive crisis, and that's exactly what it is. It is an extremely elevated blood pressure, and it is considered a crisis. They have to have medical interventions right away. So this is when the blood pressure is severely elevated, requiring immediate treatment to help preserve the organ function and help maintain life. So examples of when we would see a hypertensive crisis, we see them a lot associated with pregnancy. We try to control it. Sometimes we can't. Sometimes the intervention is that the mom has to give birth to the baby. That's the only way to bring down the mom's blood pressure. We see it in heart failure sometimes, renal failure, diabetes. Some patients, if they have what's called a dissecting aneurysm, which is a tear in one of the arteries in the lining of the heart, we'll see that they develop this hypertensive crisis. It's very common after a myocardial infarction. Remember, those sustained periods of high blood pressure cause a heart attack, so we see that very commonly. We also see it after vascular surgery, and then we see it in patients that have cerebral edema and patients that have recently had a cerebral hemorrhage. We define a hypertensive emergency as a blood pressure greater than 180 over 120, accompanied by evidence of actual or impending organ damage. So signs of crisis would be they could have nausea and vomiting, severe headache, diuresis, they're going to be peeing a lot, decreased mentation. So that level of consciousness is going to be compromised because the blood pressure is so high, all that oxygen-rich blood is not getting to the brain. The brain is an organ. You guys have to remember that. We might see seizures, eventually coma, blurred vision or loss of vision completely in some instances, and then numbness and tingling in the limbs because that good blood flow is not circulating as it should be. For patients that have this, it's an emergent problem, and the goal is to reduce the mean arterial pressure by 25% in the first hour. Do you guys know what your mean arterial pressure should be? You guys learned that? It's okay. You guys might not have yet. They might not even talk about it in the program. It should be 65. So you want to, if it's higher than that, you want to reduce it. So medications of choice. So we're going to choose medications that have an immediate effect. We're not going to choose them, obviously, the doctor is, but we're going to administer them. So some of the medications that you might see prescribed are sodium nitroprusside. So this is your Nipride or your NitroPress, nicardipine, hydrochloride, also known as Cardine. You might see Vasotec or nitroglycerin. Nitroglycerin is also Nitrobid and Tridil. It's all, depending on what your hospital carries, you may see those different varieties. So one of the things that we think about with a hypertensive crisis is, or an emergency, is that we want to lower that blood pressure, but because it's been sustained at such a high level for so long, we can't just bring it all the way down to 120 over 80 because that's going to cause worse damage. So we want to lower the pressure, but we want to do it gradually. So you might see that maybe they were 180 over 20, and then maybe 7 to 8 hours later, maybe they're 101 over 98, which is still alarming for a nurse. And you might call the doctor and they'll be like, that's okay. This is where I want them to stay, even for maybe 3 to 4 days. They might want them to just hang out at that level because they're doing it very slowly to avoid them adverse side effects. Hypertensive urgencies, so they are not quite as severe as the crisis. So this is defined as a blood pressure greater than 160 over 100 without evidence of target organ damage. So remember, a hypertensive crisis was accompanied by evidence of actual or impending organ damage. So that's a big difference. You guys need to know that. Symptoms will include a severe headache, epistaxis, dyspnea, and anxiety. What medications are we going to give? These are usually oral agents, sometimes IV, depending upon whatever else they're experiencing. So we're going to give those beta adrenergic blocking agents. So labetalol, which is also normodine or tranidate, or you're also going to give those angioconverting enzyme inhibitors, so captopril or capo-10, and then you can also give those alpha-2 agonists, so catapres and clonidine. So you will see a lot of your patients, remember we talked about medications that were created to treat one illness, but then as an added bonus, we have seen in different case studies that they also cause or can treat other issues. So clonidine is one of those medications. So we can give it for blood pressure, but we also give it to patients who have anxiety. They take it every day, sometimes to sleep and to manage their anxiety. So those patients that take this medication, we're always monitored, even though they don't have low blood pressure per se or high blood pressure, they're still going to take it, and we're going to monitor their blood pressure because we know it has the capability of dropping their blood pressure. So precautions are needed just to avoid hypoperfusion. So we don't want that blood pressure too low and any kind of ischemia. So other interventions include that the patient is going to verbalize comfort. You're going to have that objective data that they look more comfortable now. They're not sweating. They're not scared. They don't appear to have anxiety. They appear nice and calm. The patient's going to state that they feel better. You're going to assist with position changes and hygiene. So these patients, maybe they're not normally a high fall risk, but they are now. One, because their blood pressure is so high, and two, because we're going to be lowering it. We want them to preserve their energy. We want to establish a lot of rest and reduce their activity. So if they've gone for a couple tests in the morning or they work with physical therapy, then we want to make sure that they have a few hours in the afternoon where they can rest because their body needs to relax. We want to try and maintain a quiet, relaxed environment as much as possible. That is not always possible in the hospital. We can give PRN anxiety medicines, so those benzodiazepines or analgesic agents. And then we want to just give them a lot of education, teach them what they need to know about their recent diagnosis, any procedures that they're going to have because of it, and any treatments that we might do. And then we also want to remember about our communication with other healthcare members of the team. So it's not always just going to be you and the nurse. It's going to be social work that's going to be looking out for them once they leave. It's going to be that nutritionist, the doctor. There's a lot of people, physical therapy, occupational therapy. And this slide is on here twice. Sorry about that. Let's see. All right. So what are some related nursing diagnoses? So knowledge deficit related to information misinterpretation or unfamiliar with information resources. Risk for ineffective therapy regimen management. So this would be related to non-compliance with treatment. Risk of target organ damage related to clients stopping taking medication. So this is something that you're going to see. This is one of those illnesses where you're always going to see patients that stop taking it. Same thing with mental health. You guys learned that medication management is not easy for a variety of reasons. And any type of health diagnosis where you have to take medication is going to be the same thing. And it happens for a variety of reasons. I remember my husband, who has always been pretty healthy, but he has like genetic disorders in his family that cause hypertension. So he's had hypertension for several years. And we went through a period when he first was diagnosed with hypertension. He would take his blood pressure medicine, and then he was always good about monitoring it. And then he came to me one day and he was like, I don't have to take my blood pressure medicine anymore. And I'm like, you don't? I'm like, that's great. The doctor said you don't have high blood pressure anymore. And he was like, no, but I've been taking it every day and it's great. It's really low. And I'm like, well, duh, because you've been taking your medication. So you need to keep taking your medication. So they need, you're going to see this where they're not compliant because they really think that they don't have that issue anymore. So dealing with patients that are non-compliant is something you guys need to learn to do. Recognizing that they're at risk for that target organ damage, educating them about that. Ineffective tissue perfusion, we know that's a risk. Imbalanced nutrition, risk for more than the body requirements. Fatigue related to that altered body chemistry. Ineffective sexual patterns. These could be from different side effects of medication. Ineffective coping skills, getting a diagnosis like this and having to make all of these changes all of a sudden. I have to lose weight. Now I have to go to the doctors. Maybe they don't have insurance. That could be a huge issue for them. Losing weight, watching their diet. This is all very overwhelming. They might not be able to cope well with it. Potential for cerebrovascular hemorrhage and potential for retinal hemorrhage. So test your knowledge. At a community center, the nurse instructs men and women about the signs and symptoms of hypertension. Of the following people who are present at this discussion, whose blood pressure is most important for the nurse to assess? A 75-year-old African-American man, a 50-year-old executive who lifts weights, a 35-year-old woman who weighs 120 pounds, and a 60-year-old man with atrial fibrillation. Lynette, what do you think? You want to answer the question?
Yes, I think maybe it's either the 60-year-old man with atrial fibrillation or the 75-year-old African American. I don't know which one.
Okay, so if we look at the 60-year-old man with atrial fibrillation, so he could have very controlled blood pressure, but not and still have AFib. That's completely possible. The 75-year-old African-American man, that is the answer, because we said in the very beginning part of the slide that African-Americans are most at risk for developing hypertensive issues. So it's important that you guys know which group of people are at the highest risk. So it's going to be the African Americans. So that is the correct answer. All right, so while getting a blood pressure assessment, a client asks the nurse why it is important to control hypertension. What nursing response is most accurate? Sustained hypertension predisposes to narrowing of the cardiac valves. Sustained hypertension decreases the lifespan of many blood cells. Sustained hypertension leads to the formation of venous blood clots, or sustained hypertension compromises blood flow to many vital organs. Let's see. How about Ariel?
I think sustained hypertension compromises blood flow to many vital organs.
Yes, very good. Good job. That's the answer. Yep. That is the big take-home effect. You guys should think of hypertension and then think of all of our body organs shutting down. Kidney failure, liver failure, the whole 9 yards, because that is the issues that you're going to see related to hypertension. Very good. When obtaining a health history from a client, what finding is most suggestive that the client is hypertensive? The client experiences occasional heart palpitations. The client has observed blood in the urine. The client has had unexplained nosebleeds, or the client has difficulty sleeping at night.
Was it the first one?
It is not the first one. Good try, though. I could see why you chose that.
I would say
Is it the nosebleed?
Nose bleeding.
No,
No.
that is something that you would see.
Is it difficult sleeping?
Yes, good job.
Mhm.
Good job, Martina. So a lot of you are probably like, what, why? So in patients that are overweight, we know that when you're overweight, that puts you at risk for hypertension. If you're overweight, it also raises your risk of developing sleep apnea. So we see a lot of patients that have sleep apnea and hypertension. Okay, so you guys need to think about your comorbidities. Now, the nosebleeds, I completely get it. We said we would see hematuria, especially in that crisis, and the heart palpitations. But this question says which finding is most subjective. Okay, so you need to look at those key indicators when you guys are looking at those questions. All right, so now we're going to talk about myocardial infarctions, MIs, heart attacks, all the above. An MI occurs when there is a prolonged total occlusion of a coronary arterial blood flow. It is an area of tissue that dies because we're not getting adequate oxygenation, an area of tissue inside the heart that actually dies. The larger the necrotic area, the more serious damage you're going to see. So our causes are going to be it could be a thrombosis secondary to arteriosclerotic disease and atherosclerotic changes. We could also see it as a result of arterial spasms. So we know patients that, we're going to talk more about this, that don't have great diets, or they have some kind of genetic predisposition, they're more at risk for having high cholesterol levels. And cholesterol is a fat, it's going to build up on your arteries, and then they're going to get thick. And as that cholesterol starts to build up, what once was a nice wide vessel for all your blood to go through is going to get smaller and smaller and smaller until it completely occludes. And then when it completely clamps down, that blood flow isn't going to get through anymore. And that's when you're going to get that ischemia, because you're not getting that oxygen to that area of the heart. And you're going to have that heart attack. So what would a heart attack look like? So the patient might complain of sudden onset of substernal crushing pain. They might say that it's tightness. It could be severe. It might even be unrelieved if we give them nitroglycerin. Sometimes it will be relieved, sometimes it won't. Some people won't have chest pain. They'll complain of just pain in the middle of their left side of their shoulder. Some people will say they had pain in their chest and it circulates back to their back. Some people will say it's in their chest, it goes into their neck, through their jaw, over to their shoulder and down their arm. Some people will just complain of arm pain. It's very different for each person. They might complain of shortness of breath. They might have a near syncopal episode, or they might have a syncopal episode and they might pass out, lose consciousness because they're not getting that blood flow. Something that we see in a lot of people, especially women, they complain of nausea and vomiting, extreme fatigue and weakness, especially with women. The side effects that we see for women, and we're going to talk about this in another slide, are completely different and much more vague than they are for men. So the outcomes of MIs for women are often worse because the symptoms are so vague and they just, write them off as, I'm just really tired today, or, I pulled a muscle in my chest or something. So they don't address it. So sometimes they will actually die or suffer long-term damage because they didn't address the issue. So extreme weakness, sweating, and denial is common because they write them off for different things. So what are we going to do? We're going to talk about that in a couple more slides, but we're going to give certain medications. We're going to put them on a heart monitor. They're automatically going to get high cholesterol medicine. They're going to get a daily aspirin to help keep that blood thin. They're probably going to go for a cardiac cath, depending on how bad the blockage is. We're going to give them morphine. So we give them something called MONA, morphine, oxygen, nitro, and aspirin. So morphine is going to relax how hard the heart has to work to make the blood flow a little bit more efficient. We're going to give that nitro to control those pain symptoms that we're seeing, the oxygen, because if they have a blockage somewhere, they're not getting that oxygen-rich blood to those areas. So we want to pump more oxygen in. And then we give them an aspirin because we want it to thin the blood. Sometimes they need surgery, a pacemaker, and we would want to avoid caffeine, but we're going to talk more about that. So what are the risk factors of developing a myocardial infarction? So physical inactivity, sedentary lifestyle, not exercising. Our heart is a muscle, it needs exercise. Smoking causes vasoconstriction in your vessels. Alcohol consumption. Dyslipidemia, so high cholesterol, increases your cholesterol levels, diabetes, hypertension, and obesity. So what are the complications of a heart attack? Well, we could see arrhythmias or dysrhythmias. Remember, we said these are used interchangeably. These are going to be changes from the normal sequence of those cardiac impulses that result in erratic heart rhythms or rates that can be too fast or too slow. So basically what's happening when you have a heart attack is you're going to see a huge electrolyte shift. When that happens, lactic acid is going to build up in the myocardium. That's where you're going to get that pain. More than 50% of deaths from MI occur within 72 hours because of this reason. Abnormal rhythms can be fatal in just a few minutes. So these are life-threatening emergencies. We need to address them right away. We need to recognize them. When your patient says, I'm having chest discomfort, you better be in that room as quick as possible with that EKG, letting that doctor know. You know, if you have a tech, get that tech in there, have them do an EKG while you're on the phone with the doctor. They can develop cardiogenic shock. So we're going to talk a lot about shock in our final lecture on Monday or Tuesday. So we see a high mortality rate with cardiogenic shock. It occurs when 40% of the left ventricle has lost the ability to pump effectively. We can't regain that back in a timely manner, so we ultimately lose the patient. We could have a ventricular rupture. So this is where you develop a soft necrotic area in the interventricular septal. That area can rupture. You're going to see dyspnea. You're going to see rapid right-sided heart failure, and then these patients will develop shock. That's not something I've actually ever seen in the clinical setting. It happens, but I've never seen it. We can have a hemopericardium. So this is where our blood fills into the pericardium area, and they can develop a cardiac tamponade. And this is a very, very, very poor prognosis. Patients do not usually recover from this. And then we can have a ventricular aneurysm. So, there's going to be a bulging of a portion of the heart where it is affected by that myocardial infarction, wherever we see that necrotic area. We can also see an arterial embolism. So this is where clots can form in the cavity of a ventricular aneurysm. We can see a venous thrombosis. So, we're going to see those in veins of those lower extremities and in the pelvis area. We could see a pulmonary embolism, usually going to be a very sudden onset. Patient is going to complain of chest pain, dyspnea. They're going to have cyanosis. They might even have blood-tinged sputum. If they're on oxygen already, you're going to see a marked decrease in their oxygen level. Pericarditis, so this is inflammation of the pericardium. They may even need a pericardiocentesis to help remove all that extra fluid. And they might have mitral insufficiency. So mitral regurgitation, this is where blood not only flows forward into the aorta, but then it's also going to come back into the left atrium. Assessment findings. So men typically experience sudden, severe chest pain. Unusual substernal pain may radiate to the shoulder, the arm, the teeth, the jaw, or the throat. Profuse sweating, shaking, nausea. Women, like I said, have the more vague symptoms, that unexplained fatigue. It's very common. I've seen many patients that just say, I never had any chest pain. I just woke up and I was exhausted all day. I just wanted to take a nap. I think we can all relate to that. We've all experienced that. Abdominal pain sometimes, and then shortness of breath. Also, sometimes women will be more apt to experience just that jaw pain. Unlike angina pain, rest and sublingual nitrates do not relieve MI. So remember, we said in our last lecture, that patients that have heart issues will get angina when they walk. They'll get that chest pain, or they'll get that pain in their legs. Well, once they sit down and relax, that pain resolves itself. It's not going to resolve with an MI, and it can last for hours or days. Your patient might say, I've been feeling like this for 4 days, and I just decided to finally come in. So diagnostic testing. So we are going to look at a variety of different lab tests. We do what we call serum enzymes. Mainly the ones that we look at are our troponins. We also look at CKMB. Sometimes these enzymes are secreted when there's been damage done to the heart. Our troponins are the most indicative of any type of a heart attack. Our CKMB also is. We use that in conjunction with our other tests, but sometimes we see patients that will have other issues going on that will cause these to be elevated, that CKMB. And sometimes if the body is under a lot of stress from other issues, they can cause high amounts of troponins to spill into the blood. And it'll look like they're having a heart attack, but they're not. So we kind of look at the general picture. We look at all of their enzymes along with their symptoms and other things. So when we look at troponins, these are only going to be present in our myocardial tissue. Therefore, that's why it's the gold standard for determining heart damage. Whenever there's heart damage, they leak out into the blood, and we can see heart damage early on in the stage of an MI. When we measure troponins, usually you're going to see that they're done in threes. We usually like to watch them if they're negative. If they are negative times 3 is how we say it in the clinical setting. We've drawn them 3 times over 8 hours apiece. That's how we do it. So we do it at 12, then we do it again at 8, and then another 8 hours after that. If they've been negative all 3 times, then we say that they're not having an MI. If they're elevated and they start to elevate as they go on, then we know that that is indicative of a heart attack. Again, classic heart attack symptoms: anxiety, crushing chest pain, difficulty breathing, nausea, vomiting, sweating, and pale skin. So sometimes we have to do medical or surgical management. So medical management is directed towards reducing that tissue hypoxia as fast as we can, relieving pain that the patient is experiencing, treating shock if present, and then we want to alleviate any of those dysrhythmias. We want to prevent them, and we want to fix them if they actually happened. So we're going to do thrombolytic therapy. So these are IV drugs that dissolve blood clots. We have a protocol which is called door to needle. So in any patient that's coming in that has been suspected of having a MI, it is every facility's goal that they get the patient in the door at the hospital and to a cardiac cath, or to get this medication within 30 minutes, but no more than 90 minutes. So it's really hard to have that done in 30 minutes. But if we can get it done by 90 minutes, then they're still a candidate for this thrombolytic therapy. It's a tissue plasminogen activator. We call it TPA. You'll hear that in the clinical setting. It dissolves the thrombus and it restores that circulation of the oxygenated blood to the myocardium. If it's administered within the first 2 hours after the initial onset of symptoms, an MI can be greatly minimized. There are certain contradictions in your book. Box 25.4, you guys should look that up. You guys are going to want to know the information in there. Those are contradictions for thrombolytic therapy. Not everybody is a candidate. Might be that they already take blood thinners. If they're on warfarin, Coumadin, things like that, not candidates. If it's been a certain amount of time, it's been 3 to 4 hours, they're not going to be a candidate. And there's other things in there, so you guys should read about that. Sometimes we have to do surgical management. Sometimes they have a blockage and we have to do a CABG. So we go in, it's a coronary artery bypass graft. In the hospital, we call it a CABG. So if you hear someone say the patient had a CABG, they had a CABG times 2, times 3, times 4, it depends. If they're saying 2 times 3 times 4, that means that they've had multiple arteries that were involved and they had to bypass them. So they go in, they cut off the area where there's not any blood through, they redirect it to another area to restore that blood flow. It is a major surgery, open heart surgery. They can do a cardiomyoplasty and they can also do something called a heart wrap. So these patients will always need cardiac rehabilitation. So they have that heart attack, they're not going back to work, they're probably going to be off 6 to 8 weeks. They need to follow up in the outpatient setting in a medically supervised program. They need a lot of one-on-one work and education. So these outpatient programs combine exercise and educational activities to help speed their recovery. And then we want to reduce and prevent any recurring episodes. So we want them to know how to eat healthy and know how to exercise so that this never happens again. So when we assess these patients, what are we going to be looking for? What do we want to know? So we want to know their pain. Describe your pain on a scale of 0 to 10. Where is it? What type of pain is it? Is it crushing? Is it squeezing? Is it pressure? How long does it last? Does anything make it better? Does anything make it worse? And is it radiating? Does it radiate to your arm? Does it go to your jaw? Does it go to your back? You're going to want to do vital signs every 30 minutes until the patient is stable, and then every 4 hours after as needed. You're going to look for the presence of any nausea, vomiting, diaphoresis, or anxiety, because these are signs of heart attacks. We are going to monitor their oxygenation saturation with that pulse ox. They're probably going to be on a continuous pulse oximeter, because we need to make sure that we're keeping a normal level of oxygen in their body, because they have that blockage somewhere. So we know they're not getting a lot of blood flow, and blood carries oxygen. We're going to monitor that cardiac rhythm. They're definitely going to be on a telemetry floor, on a telemetry monitor. They're probably going to get a baseline EKG when they get to your unit. Usually they're stable by the time they come up to the unit. They stay in the emergency room until they get to TPA. We don't give that on the med-surg units. We can do it in the ICU, but not our med-surg units. We're going to be listening to heart sounds. We're going to be listening for any irregularities, any irregular rhythms, murmurs, gallops, anything like that. So we want to also listen for lung sounds, because we know that in certain heart issues and in heart failure, we can hear advantageous lung sounds because we start to get that backup of fluid in the lungs. Or we want to check the quality and the presence of those peripheral pulses. Compare left to right with both your upper and lower, and then really make sure as you go to the lower extremities, you're doing all the pulses. So the popliteal, the dorsalis pedis, the posterior tibial, because the farther away your extremities are from your heart, the less likely you are to have that good blood flow. So you want to note any deficits. We definitely need to promote bed rest for these patients. We need to preserve all of their any kind of strength that they have. We need to limit their activity. They shouldn't be working with physical therapy. If it's an older patient and the bathroom's far away, make sure you have a bedside commode there. If it's a male patient, really try and encourage the use of a bedside a urinal, so that way we can preserve their activity. We're going to be monitoring those results of those serum cardiac monitors. The doctor is going to look at them, but you should also be looking at them too. You want to know the stability of your patient. So you know they're drawn every 8 hours. Make sure you go in there on that 9th hour and look for those results, and then communicate it with the doctor. Let the doctor know that you're on top of things and you're really monitoring that patient. And then you want to establish a thorough history of baseline data about your patient and any disorders that they have. So do they have diabetes? You know, diabetes, hypertension, MIs, strokes, they all go hand in hand. Have they had any recent strep infections? Because we know that the damage that that can have on the heart, right? With rheumatic fever, if it's uncontrolled. Do they have an allergic reaction to anything that could be in that TPA? So that's streptokinase, and then any findings that would disqualify them from thrombolytic therapy. And then their drug history for any prescribed medications they take, any over-the-counter medications, and then don't forget those CAM and herbal products because they can cause a lot of problems in our patients. All right, so we did talk about this a little while ago, immediate treatment of an MI. You're gonna do morphine, oxygen, nitroglycerin, and aspirin. Morphine is gonna decrease the workload of the heart. Oxygen to get all that rich oxygen into the blood. Nitroglycerin to relieve that chest pain, and then aspirin to thin the blood. The other thing that we put them on automatically, which is not on here, is we put them on a cholesterol pill, usually Lipitor. Atorvastatin, that's the other thing we give them. All right, so bed rest, oxygen therapy, opioids, we're going to give them morphine, monitoring, vitals and other blood work, anticoagulation therapy, and reduce the clot size. Nitroglycerin, so what does it do? It relaxes the vascular smooth muscle. Once we get that muscle relaxed, it's going to decrease that blood pressure, and it's going to enable the heart to maintain an effective coronary perfusion pressure. It works very quickly if we use sublingual tabs or if we do translingual spray. If we do a patch, which that would be your nitro bid. If we do nitro in ointment, sometimes we can put like this nitro ointment on their chest, or any type of sustained release tablet is not going to be quick to work. So you would not want to use the nitro bid or the ointments or the sustained release tablets in an emergency. So nursing diagnoses, we're definitely going to see that acute pain related to that diminished myocardial oxygen. We're going to administer oxygen at 2 liters a minute by nasal cannula or as the doctor prescribes. We're going to prescribe sublingual or spray nitro every 5 minutes, up to 3 doses. If pain is still unrelieved, that's when we would give up to the 3 doses, but they have to be 5 minutes apart. We are going to administer prescribed IV morphine to help reduce the workload of the heart. We're going to see anxiety or fear related to perception of impending doom, concern over actual or potential lifestyle changes, and then worry concerning their family situation. We're going to make sure that we explain the procedures to the patients. We want to promote rest, acknowledge their grief, so we want to provide empathy, and then administer any type of sedatives that are ordered that can help reduce their anxiety. We have a risk of hemorrhage related to thrombolytic therapy, and then risk for arrhythmias related to reperfusion of the myocardium with that thrombolytic therapy and instability of the conduction system in the heart. Patient education. Sometimes they might go home on nitroglycerin. So if they're in the hospital, we want them to know when they should ask for it and how often they can have it. When we go home, we want to make sure that they have it and they know how to use whichever kind they're taking and how often they can have it. We're going to talk about those diet modifications, because if they have a blockage and they had a heart attack, they probably are not eating the proper diet. Medication regimen, we want them to take the medications that they need to prevent the hypertension and another heart attack. If they smoke, we want to definitely talk to them about reducing it or quitting altogether. Same thing with alcohol, modifying their intake. We want to establish those physical limitations. When they go home, they're going to be out of commission for 6 to 8 weeks. They're going to be going to cardiac rehabilitation. So we don't want them to have a heart attack, release them next Monday, and then they go out and run a marathon. We want them still to do things that will promote rest. We want to encourage them to monitor their blood pressure at home and communicate that information to their primary care physician. We want to give them tips for avoiding stress if they're heart attack was related to stress. And then we want to talk about the importance of continued medical supervision with their primary care doctor. And now they brought themselves a cardiologist. So they're going to have to follow up with their cardiologist as well. So how will we know that our interventions have been effective? Well, the patient is going to state that their pain is reduced to a tolerable level. They're going to state that their anxiety is now reduced and that the client has self-reported tolerance to their stressors. That's probably not something you're going to see in the clinical setting. That is something that would probably be a more appropriate evaluation in the outpatient setting. They might be able to report ways to decrease stress, but not sure that they would see an actual removal of all the stressors in their life, especially if they just had a heart attack. And the client will report decreased anxiety and fear. All right, so we are halfway through now. We still have to cover STEMI and non-STEMI. Do you guys want to take like a 5 or 6 minute break? Yes. Okay, let's take a 5-minute break and then we will come back and pick right up. That's terrible. Not okay. All right, guys. So let's go ahead and restart. So STEMI versus NSTEMI or non-STEMI. So NSTEMI stands for a non-ST segment elevation. It's a type of a myocardial infarction. Typically, NSTEMIs are less damaging to your heart. They're not as severe. So in an NSTEMI, you will see a depressed ST wave or a T wave inversion. So you can see at the top on the right-hand side here. So this is your normal ECG or EKG right here, right? This little area in between here is your ST segment. So this is your P wave here from the start of this little dot where I have my arrow up to the top and then back down. That's your QRS. So this little area right here is Q. When you get to the top, it's R. When you get to the very bottom, we call it the S. So that's your QRS complex. So there's your S, here's your T. So in between, that's your ST segment, okay? This is what a normal one looks like. So with an NSTEMI or a non-STEMI, you can see this ST depression. So you can see that there's a marked indent right there compared to the other one. Or you can have an inversion. So instead of the T wave going up, you can see right there, it goes down. So if you see those on an EKG, these would be indicative of a NSTEMI. There will be no progression to that Q wave like you normally see, and then you'll have a partial, this is indicative usually of a partial blockage to the coronary artery. So if your patient has a STEMI, which is a much more common and severe type of a heart attack, you would have an ST an elevated ST wave. So you see that big elevation right there? That would be that ST elevation. You would see some progression to the T wave, and this would be a full blockage of the coronary artery. So you have STEMI versus NSTEMI. Oops. Cardiac dysrhythmias. So cardiac dysrhythmias are abnormalities that are going to originate in a couple places. They can start in your atria. They can start in your atrioventricular node, so your AV node, or they can also happen in your ventricles. So when we talk about normal sinus rhythm, this means that our patient's heart is beating between 60 and 100 beats per minute. We know that that's normal. What's going to happen in normal sinus rhythm is your SA node, which is the pacemaker of the heart, is going to initiate that impulse. That impulse is going to travel to your AV node. We want that to occur in usually 0.12 to 0.20 seconds. That's a normal time. An upright P wave before each QRX complex. So let me see, go back to this one. So for each one of these rhythms, you know, we said that you're going to have a P, a QRS, and a T. So in order for each heartbeat here to be considered normal sinus rhythm, you always have to have this P wave. The absence of a P wave is usually indicative of irregularity or AFib. So you want to have a P wave before every QRS. Okay, so that's what that means in that slide that I was just talking about. So that impulse is going to travel to the AV node. You're going to have that upright P wave before each of those QRS complexes. The ventricles are going to depolarize. Usually that takes about 0.12 seconds or less in that QRS. So if you measure that QRS, we want it to be less than 0.12. And then that impulse is going to occur regularly. So when we look at it, we want it to see that it's happening in a regular basis. So in the hospital setting, in practice, we would measure it. Some of our computers are set up that we can just measure it right there. They have a little machine that does it, or you can buy something and you can do it by hand. So we want a P wave before each QRS. We want our impulse to travel to that AV node. We want it to be between 0.12 and 0.20. And we want our ventricles to depolarize in 0.12 seconds or less in that QR complex. And we want that impulse to be regular. That is all the criteria for normal sinus rhythm, which you guys need to know. We're going to see that on your exam. Atrial dysrhythmias that originate in the sinus node, you're going to see sinus bradycardia. So that's that decrease in heart rate. And we're going to see sinus tachycardia. So these are atrial dysrhythmias. Atrial dysrhythmias that develop in sites outside of that sinus node, you're going to see your premature atrial contractions. You're going to see, and we're going to talk about these, supraventricular tachycardia, atrial flutter, and then atrial fibrillation. So this is what normal sinus rhythm looks like. You have that little P wave there before each of your QRSs. You have that nice T wave. If you measured this out, it would all meet the criteria that we talked about on the other slide. So that QRS less than 12, PR interval 0.12 to 0.20. And I think the other night when I was talking to you, I told you guys that each of those boxes, remember we had a slide that was talking about each box, and I think I told you it was worth 0.4. It's 0.04 that each box is worth. So that was my mistake in saying that. And then we want them to be regular. We want 60 to 100 beats per minute, regular. We want it to meet all this criteria. That's what constitutes normal sinus rhythm. So sinus bradycardia. So bradycardia is an arrhythmia that originates in the sinus node of the right atrium. It's a dysrhythmia that proceeds normally through the conduction pathway, but at a slower rate. So less than or equal to 60 beats per minute. So what are the causes? Well, sometimes if your patient is very healthy, they're runners, they're well-toned, they're going to have lower heart rates because their heart is healthy. So they could be 50s, 52s. Certain heart disorders cause it. Sometimes patients that have increased intracranial pressure will have bradycardia, hypothyroidism. If a patient is taking digitalis, which is a medication, that can become toxic and cause bradycardia. And the danger is that the slow rate is going to be insufficient to maintain cardiac output. So you're not going to get that good circulating volume from your heart because it's not beating as often as we need it to. So if it's not beating as we need it to, we're going to suffer damage to our organs, right? Our kidneys, our liver, our brain. So medical management, usually what we do is we give atropine sulfate. It is a cholinergic blocking agent, and it's usually given IV, and it increases those dangerously slow heart rates. So this is what bradycardia would look like. So you can see it's a lot slower compared to the other side. So it's going to be a heart rate less than 60, still going to be a regular rhythm. It's going to look like normal sinus rhythm, but it's going to be slower. There is going to be a P wave before each QRS. That PR interval is going to be between 0.2 to 2.0, and then that QRS is going to be less than 0.12. So then the opposite of sinus bradycardia is sinus tachycardia. So these are the arrhythmias that are going to originate in the sinus node of the right atrium. A dysrhythmia that proceeds normally through the conduction pathway, but it's going to be at a faster rate, usually 100 to 150 beats per minute. What causes tachycardia? Well, it can be a physiologic response to maybe strenuous exercise. We see it with anxiety, fear, very common with pain, fevers, hyperthyroidism. If a patient is hemorrhaging because that circulating volume is diminished, so the heart is pumping faster to get more blood out. See it in shock, and then also hypoxemia. So this is sinus tachycardia. So still a normal rhythm, not a normal rhythm, but you have all the components. You have that P wave, the QRS, but it's occurring more frequently. So these are heart rates greater than 100. Your rhythm is going to be regular. It's just going to be faster. That P wave, you're going to have it before each QRS. It's going to be between 0.12 and 0.20, and your QRS is still going to be less than 0.12. All right, so this is a comparison. So, you know, these are all happening in that SA node. That's going to be your normal sinus rhythm, your sinus brady, and your sinus tachycardia. You guys need to know what's causing these problems, where it's starting, what's causing it. Then we have premature atrial contractions. We call them PACs. This is when neural tissue inside of the atrial conduction system initiates what we call an early electrical impulse. So it happens before it should. And it's going to be identified as an irregularity on the underlying rhythm. Causes: too much caffeine, nicotine, and any other issue that could stimulate our sympathetic nervous system. Heart disease can cause it, certain metabolic disorders, hyperthyroidism can cause it. So when our PACs are isolated or they're infrequent, there is no cause for alarm. Maybe sometimes at night, if you ever lay down and you feel like if you're under stress, you might feel like a crazy beat in your heart. Those are usually PACs. There's no pain. They don't happen all the time. They're infrequent. We don't have to worry about them. There's no need for worry. So this is what PACs would look like, see how you have like it's regular, regular, and now that's that irregular rhythm. So it happened too early. You didn't get that good break in between the first beat to the second. So you have that little irregularity right there. So that's what we call an isolated PAC. So your heart rate, doesn't matter what your heart rate is. We can see it at any different point in time. Your rhythm is going to be irregular. It's not going to be a regular rhythm. This might only happen. So usually when you pull your strips in the morning in the hospital, you go in and you do it at the beginning of your shift. You might not even see it. It could have happened once at 3 a.m. You might not see it again on your shift. So you might not even recognize it. If you see that another nurse documented that, then it's something that you should be aware of. Maybe you'll see it on your shift and nobody else will see it. Maybe it won't happen the whole rest of the time he's there. So it might not always be something that you're aware of. It's something that you notice and they didn't tell you in report. This is something that you would want to report to them, to the next nurse. Again, that P wave is going to be premature. And because it happens so quickly, it might not even be there. It might be abnormal or it might be hidden. So that PR interval should be less than 0.20. And the QRSs that you're measuring should still be less than 0.12. So now we have supraventricular tachycardia, or we call it in the hospital SVT. So this is a dysrhythmia in which the heart rate has a consistent rhythm, but beats at a dangerously high rate. So greater than or equal to 150 beats per minute. So if your patient has tachycardia and it's between 100 and 150, it's just tachycardia. Okay, if it gets to be 150 or above, then we call it SVT, supraventricular tachycardia. So diastole is shortened, and the heart does not have a sufficient time to refill. The cardiac output drops, and it's going to be dangerously low because we're not going to be able to perfuse all of our organs. We don't have that sufficient cardiac output because that diastole period is stopping. So we're not getting the normal amount of blood in that refill to pump out. The assessment findings, these patients may have chest pain. Obviously, they're going to have tachycardia, angina, hypotension because we're not getting that good circulating volume out. They might have near syncopal episodes or actual syncopal episodes. And then we're going to see reduced renal output because those kidneys are not being perfused. So medical management, what are we going to give? We're going to give digitalis or adrenergic blockers, and even we can give calcium channel blockers. This is what SVT looks like. You can't even see a P wave in there. There is a P wave in there, but it's hidden because it's happening so frequently that you can't see it. So this is your SVT. You guys need to know what these rhythms look like because you're going to have to identify them on your test. I think there's at least 2 of them that you guys are going to have to identify. So make sure you know what your rhythms are. Atrial flutter. So this is when there's a single atrial impulse outside of that SA node, which causes the atria to contract at an exceedingly rapid rate. So it's going to be 200 to 400 contractions a minute. That's a lot. The patterns that you see, those are little flutter waves. They look like, some people call them shark teeth. That look like little razors. They just think that they look like shark teeth. So that's how people say, if they see the shark teeth, that they know that it is a flutter. Atrial waves in the A flutter have a very characteristic sawtooth pattern. AFib. So this is when the atria is actually quivering, I cannot talk. Really, I've had like 2 hours sleep because my newborn grandson is staying with me. So forgive me if I'm saying things that don't sound normal. The atria quiver rather than contract. The ventricles respond to the atrial stimulation randomly, causing irregular ventricular heart rates. Their ventricles are not picking up and responding on a normal basis. It may even be too infrequent to maintain cardiac output. the complication, formation of blood clots within the atria. So remember, whenever you guys think about AFib, you should think that your patients should be on a blood thinner for life, because they will never have controlled, well, I don't want to say never have control. Some people that have AFib, we do control it with medication. Some people get control and they never go into AFib again. Sometimes people throughout the day go in and out of AFib. If they're on the monitor, they might be in AFib in the morning, then in the afternoon, they're completely normal sinus rhythm. And then by shift change, they're back to AFib again. But they always have to be on a blood thinner because they don't have that consistent perfusion. So we have the ability that blood's going to pool somewhere and cause a blood clot. And then we know that these patients are susceptible to having a stroke because the emboli can enter the circulation. So this is what AFib looks like. We say in the clinical setting, if there is no P wave, if there is no P, then fib it out. So you don't see a P wave, we always call it AFib. This is irregular. You can see how you have a rhythm here, but you're not getting those P waves. And then you have this long delay right here before you have another beat. So this is that atria that's quivering. So what are we going to do for medical management? So sometimes for AFib, we might have to do what's called a chemical cardioversion. So this is just the use of IV drugs to help eliminate an arrhythmia. We can give them heparin. We're going to prescribe this initially if the dysrhythmia lasts longer than 48 hours. Persistent AFib, they're going to be on Coumadin on a regular basis. We can give Covert, which is an antiarrhythmic drug, which is used to convert new onset AFib into normal sinus rhythm. Sometimes PO medication doesn't work, so they have to have IV medication. Anything that needs to be titrated usually can never be on a med-surg floor. It has to be in the ICU until they are stable, and then we can continue it down on a med-surg floor. Sometimes it takes several bags of IV medication to get them to convert. It can take days to get them to convert. And then we can do what's called an elective cardioversion. So if their ventricular rate is not too slow, we can hook them up and we go in and kind of do like a little shock to the heart and kind of get everything to go back to normal again and hopefully break that rhythm. Surgical management, they can do something called a maze procedure. It restores the normal conduction pathway in the atria by eliminating the rapid firing of that ectopic pacemaker using scar-forming techniques. So this can be done open chest or closed chest. And I'm not even too familiar with that. I've never seen that in the clinical setting. So your patients can also present with heart blocks. So these are disorders in the conduction pathway that interfere with the transmission of impulses from the SA node through the AV node to the ventricles. So there are a couple different types of heart blocks. You can have a first degree, a second degree, or a third degree, which is a complete heart block. So your first and second degree heart blocks, this is where the impulse in that conduction pathway is just delayed. It happens, but it doesn't happen when it's supposed to. A complete heart block is that the atrial impulse never gets through and the ventricles never, they start to develop their own rhythm, which is independent of that atrial rhythm because they're not getting that impulse. And the ventricular rate is usually going to be slow. So 30 to 40 beats per minute is what you're going to see in those patients that have complete heart block. So in order to treat these, we would do a pacemaker. Okay, you guys need to know how to treat these and you need to know what is happening in the heart that's causing them. So this is a good slide for you guys to look at. This is your different heart blocks. So you have that constant PR interval. It's going to be a first degree heart block. A variable PR interval is going to be your second degree heart block type 1. And then down here, this is your third degree heart block. So this is a little poem that you guys can learn to try and help you figure out what type of heart block your patient has. So if your R is far from P, so the only way that you would know if your R, which is your R right here, remember I showed you your QRS, if that R is very far away from your P wave, it's going to measure higher than what did we say was normal, 0.12 to 0.20. Anything higher than 0.20 is going to be not close enough to your R. It's going to be abnormal. So if it's higher than 0.20, you know that your P is far from your R, okay? If your R is far from P, then you have a first degree. We have longer drop, then you have a winky Bach. So this is what we call a type 1. We have a type 1 and we have a Mobitz 2. I know this sounds, it's really confusing, but once you guys have time to go in and look at it and study it, it's going to make more sense. So this is the second degree AV block. It's going to be longer, and then it's going to drop altogether. See it right there? There's nothing in the middle. It's going to completely drop off. Then you have, if some P's don't get through, then you have a Mobitz 2. So right here is a great P wave. Right here, P wave. Right here, there's nothing. It just stops. And then it starts again. So that is the Mobitz 2. And then if your P's and Q's don't agree, then you have a third degree. So for every, remember we said what normal sinus rhythm is. So if you know what qualifications you're looking for normal sinus, you'll know if you don't have it. So you have to have a P for every QRS. So if we look at this first one, there's your P. It's longer, but I'm just using it to show as an example. You should have your P, then your Q, your R, your S, and then your T for every normal rhythm. So here, there's a P, but it's really far. Here's a P, but where's your QRS afterwards? There's none there. And then here's your QRS, but then there's no P right in front of it. So your P's and your Q's are not agreeing. You could have a P with no QRS. You could have a QRS with no P. They're not going to be together. Okay. So we talked about PACs. Now we're going to talk about PVCs. So these are premature ventricular contraction. So this is when the ventricular contraction occurs early and it's independently in the cardiac cycle before that SA node can initiate that electrical impulse. No P wave presides first before that QRS, and your QRS is going to look very wide and bizarre. Assessment findings that you might see if you have enough of them together. You could have, the patient could show pallor, they could be nervous, they could be sweating, they could have a syncopal episode or a near syncopal episode, and they might kind of have like a fluttering in their chest. Again, for medical management, if they're just occasional and there's no pain associated, they're completely harmless. They couldn't happen when you have anxiety, when you're stressed out. If you're extremely tired, I notice that I have them a lot at the end of the day when I'm really tired and I lay down at night. A lot of times we have them during the day, but because we're busy, we don't notice them. But then when we lay down at night and our body starts to relax, we become more aware of them. So a lot of times people will come and they'll be like, whenever I lay down at night, I feel this fluttering in my chest. That's why. Alcohol withdrawal and then tobacco use. So these are, see this right here? This is your PVC. That's what a PVC looks like. And here they're happening pretty current, but like those PACs, they can be very infrequent as well. You might not even see it. If you see one, this is something that you should pass on because the night nurse might not see it or vice versa. So it doesn't happen all the time, or it can happen quite frequently. But if there's no pain and they don't have all those symptoms, then the patient's perfectly fine. So ventricular tachycardia. So this is single irritable focus in the ventricle that initiates and then continues the same repetitive pattern. Ventricles are beating extremely fast, so 150 to 250 beats per minute, and your cardiac output is definitely decreased. The client may lose consciousness and become pulseless depending on how long the dysrhythmia is present. Ventricular tachycardia sometimes ends abruptly without any intervention, but often requires defibrillation and may progress to ventricular fibrillation. So you should expect that something terrible can happen to your patients if you see this. So sometimes the monitor room will call you and say, your patient just had a 15-beat run of VTACs. I want you guys to know the terminologies that we use in the hospital. Once they have this irregular beat and you see it on the monitor, you're going to count it because you want to know how many times it happened. 15 times, 4 times, 20 times. If you see it or the monitor room calls you and tells you they have it, you need to go to the room right away and check the patient. If they're sitting there eating, talking on the phone, and they're completely fine and they didn't notice anything, no big deal. You'll call the doctor. You'll ask them, are you having any chest pain? Do you feel dizziness? Do you feel anything funny in your chest? Sometimes they might say, yeah, I felt a little bit of fluttering, or nope, I feel perfectly fine. Then you would call the doctor and you would say, hey, Dr. Gonzalez, Mrs. Jones just had a 15-beat run of VTAC. I went in and I checked on her. No chest pain, no shortness of breath, no headache. She's fine resting in bed. So then they'll either watch it or maybe they'll get an EKG if it's the first time. If it's something that happened before, then they're just going to watch it and make sure it doesn't turn into anything else. But you do want to count it. You do want to watch it. If you see this, this is a medical emergency. Your patient is probably not alive or they are dying. Their heart rate is going to stop. You would want to get the code cart and get to your patient's room as soon as possible. So this is VFib. So if you see this, you know that this is a medical emergency, okay? There's no P wave there. There's no, you have like that QRS, but there's nothing else. It's just, that's exactly what it looks like. So ventricular fibrillation. So actually, did I just say, I told you that this was VFib. This is not VFib. This is ventricular tachycardia. Sorry, this will lead to VFib. I said it the wrong way. This is ventricular tachycardia. Ventricular fibrillation comes after that ventricular tachycardia when it's not resolved. So this is the rhythm of a dying heart. PVCs or ventricular tachycardia can precipitate this. So we're talking PVCs that are continual, not just 1 or 2, and they usually have some type of a symptom with them. The ventricles are not contracting effectively. There is no cardiac output, none, because those ventricles are not contracting the way they should. Treatment, cardiopulmonary resuscitation, CPR, and defibrillation. This is what VFib looks like. There's no normal rhythm there at all. That's VFib. Diagnostic findings. You're going to do a monitor strip from your telemetry monitor and definitely a 12-lead EKG to be able to identify any dysrhythmias or potential dysrhythmias. They're going to have electrophysiology studies that could show actual dysrhythmias. They can go in and actually stimulate structures in that conduction pathway that can cause the heart to reproduce certain dysrhythmias. And it determines the best method for preventing further dysrhythmic episodes. It eradicates tissue in the area of the heart that is producing these dysrhythmias. Medical management, we're going to give anti-dysrhythmic medication, IV or PO. They are going to need defibrillation if they have VFib, only treatment for a life-threatening ventricular dysrhythmia. When would you use it? Pulseless ventricular tachycardia, so no pulse. Ventricular fibrillation and asystole. None of these have pulses. You don't want to perform defibrillation on a patient that has a pulse. When there is no identifiable R wave present in these issues. Types, you can do an automatic external defibrillator, so that's your AED, which you guys know by now. Then we can also, after we stabilize the patient, implant a cardioverter defibrillation, so an AICD, which is an internal electrical device used for certain patients that have these recurrent life-threatening tachydysrhythmias. We see them with cardiomyopathy. So it will sense when that heart starts to make that abnormal rhythm where there's not going to be any cardiac output, and it's going to shock the patient like we would with our AED and get that rhythm starting again. We can put in a pacemaker. A pacemaker is going to provide an electrical stimulation to the heart to help treat those ineffective bradydysrhythmias. So pacemakers for patients that have bradycardia. What are the different types of pacemakers? We can do a demand pacemaker, also called a synchronous. So this self-activates when the client's pulse falls between a certain level. An example is that we'll set it at 72 beats per minute. If it goes lower than that, then it's going to automatically put in that beat that it needs. Every physician will set it at what they want. It doesn't always say 72. Sometimes it's 64, sometimes it's 68. It just depends on what the cardiologist wants. Then we have one that's a fixed rate. So it's going to produce an electrical stimulus at a preset rate, 72 to 80 beats per minute, despite the client's natural rhythm. So it's always going to make that electrical stimulus to keep that heart beating over and over and over. Sometimes these pacemakers can be temporary, and sometimes, of course, they have to be permanent. When we treat cardiac dysrhythmias, we can do what's called a radiofrequency catheter ablation. The pacemaker lead is going to enter into a patient's external jugular vein. It's going to be tunneled subcutaneously between a pacemaker and that external jugular vein. Sometimes the electrode tip is going to end up at the very apex of the right ventricle. The heated catheter tip is going to go in and it's going to destroy and burn off all that tissue that's not functioning properly, that's producing these dysrhythmias. Complications can be bleeding, perforation, thrombus, and then we could even see a pericardial tamponade. So what kind of nursing care plan would we want to do for these patients? We might have a diagnosis of decreased cardiac output. We want to maintain physical and emotional rest because we want to preserve the limited amount of oxygen that they do have. We probably want to give them supplemental oxygen to help because we know that some of these dysrhythmias are going to decrease their cardiac output. Nursing diagnosis, ineffective management of therapeutic regimen might be because they aren't taking their medications like they're supposed to. We want to explain all the side effects, the dosage, and the administration of these dysrhythmic medications. Remember, just like if when you guys learned about mental health, you know, some patients start taking these medications and they don't like the side effects, so they stop taking it. So if they know the side effect and they know that it's not going to last long, they'll stick with the medication and see its way through, and then we'll have more compliance. We want to identify guidelines for withholding medications. So the doctors usually put parameters in there. So if we have a patient that has AFib, we're going to want to not give them medications that control their heart rate or reduce their heart rate if their heart rate is already lower than 60. So you're going to be responsible for looking at these patients' medications and saying, oh, this patient's on digoxin, they're on metoprolol. I'm going to do a pulse check. I'm going to monitor their heart rhythm and make sure it's within a normal parameter before I give it. Same thing with blood pressure medications. And then you're going to provide information on precautions required with that AICD or pacemaker. So with regards to the AICD, usually it'll signal the patient that it's going to happen. They'll feel something in their chest, and then it acts just like a regular AED. So you don't want to be around that patient when that goes off. So if you're the wife of a patient or the husband of a patient that has one, there's going to be a lot of education about the patient recognizing that it's going to happen soon so they can tell people to stay away from them. And then you as the care provider would also want to make sure that you knew what to look for so that you weren't touching the patient when it happened. You're going to do those 12 lead electrocardiograms. It's a EKG that's going to show you the electrical activity of the heart at a certain point in time. So before you do it, you always want to explain to the patient what you're doing, make sure it's okay if you do it. The patient always needs to be in a supine position as much as possible. Uncover those chest and limbs because you need to have access to all these areas that you see on the picture here. Identify the landmarks. Most of your EKG machines will have this nice little picture right there, so it helps you see exactly where you're supposed to put all the little stickies. Prepare the skin for electrode adherence. So if you have a chest that's extremely hairy, those little leads won't stick. So you might have to shave the patient in certain areas to get them to stick because you won't get a good reading if you just attach them to the hair and they're moving all over the place. Place the electrodes at the landmarks, and then you're going to attach the corresponding lead wires to those electrodes. So I'm assuming it's everywhere, but where I work, at the end of all these little leads right here that you're going to attach to the patient, it's going to tell you what part of the body to put it on. Very self-explanatory. And this just shows you where you're going to put the leads. You guys can read over this. But you guys know all these spots already. We've talked about these back in fundamentals when you were doing your physical assessment. And then post-procedure, the EKG, you're going to make sure that the EKG appears normal. So you don't want to have just like a lot of irregular movements. You know, if the patient wasn't still, you'll just see a lot of crazy movement. So you want to keep the leads on there. Make sure you have a great rhythm going across before you hit that button to actually capture that picture. If a repeat EKG is not needed, remove the electrodes from the patient's skin. That's so terrible when I see, you know, people that perform these procedures and then they leave the EKG strips on there. I mean, the electrodes on there, they're really sticky on the back and they heat up the longer they've been on the patient and they become really gooey. And when you go to pull them off, all the goo comes off with them and it sticks to their chest and the hair. And especially those older patients that have the more fragile skin, it can cause skin breakdown when you pull it off. It could even cause a skin tear. So please be mindful of that. You would want someone to take them off for you. So just do the same thing for them. Assist the patient with repositioning again. Remember, we had them supine. So let's make sure we sit them back up in bed, make sure they're comfortable, make sure they have their call bell, and then make sure that you leave that equipment ready for emergency use. So clean it off, put it back where you found from, where you got it from on the unit. And then always, always, always know where your code card is on the unit, know where your defibrillator is. In most settings, it's on the code card. Make sure that you have emergency equipment in the room. You should have O2 that's working. You should have your green little Christmas tree. You should have nasal cannula. You should have Yankauer suctioning. You should have your suction tubing. Different types of masks. Each facility should really have like a safety bag that includes all those things. But it's your responsibility of the nurse to make sure that you're checking to make sure that your room has all those things, because these patients can go south without any given notice, and you don't want to be searching for these important equipment that you guys need. So this is a link. You guys can click on this in your spare time. It's just going to tell you how to identify certain rhythms. It'll have, you can listen to certain heart sounds. It's a pretty good app. It's very user-friendly. And that's it. We are done. We finished up early. I didn't think we would finish that early. What kind of questions do you have?